Sir, are you able to
Yes,
hear me?
yes,
Sir, we are live. So, with your permission, shall I start the session?
yeah, you can.
A very good evening to all of you present on today's session on role of thrombolysis in STEMI. And we have as a keynote speaker, Dr. C.B. Patil, sir. Let me share an overview of today's session. The goal of thrombolysis in STEMI is to restore blood flow to the affected part of the heart muscles as quickly as possible, thereby reducing the risk of damage to the heart and improving outcomes. Thrombolysis is most effective when given within the first few hours after the onset of STEMI symptoms. And to present this topic, we have with us Honorable Speaker Dr. C.B. Patil, sir. Sir has done MBBS, MD, DM in Cardiology, FICC, FIAMS, FCSI, FIAE. Sir is also WHO Fellow in Interventional Cardiology and visiting cardiologist at Sri Shankara Cancer Hospital and Research Center at Bangalore, and sir is also teaching faculty Department of Cardiology at Manipal Hospital, Bangalore. And also sir is a visiting cardiologist at GM Healthcare. Now, without wasting any more time, I would like to handing over the session to Dr. C.B. Patil, sir. Sir, over to you. Sir, please start your presentation. Yes, it is visible. Please start.
Yeah. Thank you. I thank the IJCP for this opportunity as well as the Nishita Mukherjee. And as you know, the coronary artery disease is very common in our country, and it is also affecting the young age with the multiple comorbidities like hypertension, diabetes, and bad lifestyle, smoking habits, alcohol intake, obesity, and its bad effects. So I want to touch upon the STEMI part of it because even unstable angina, non-STEMI, sudden cardiac deaths, they are all part of the acute coronary syndromes. I'm just going to touch upon the role of thrombolytic therapy in ST elevation myocardial infarction. Is it moving now? Slide.
Sir, I can see your first.
Yeah. It has moved.
Yes, sir. Yes, sir.
Thank you. So in ST elevation myocardial infarction, as you know, the chest pain is a central pressure type, squeezing type, gripping type, heaviness, tightness, exertional or stress related, and often retrosternal, and it is left-sided, dull or aching type, which remains for almost more than 20 minutes. Of course, with autonomic symptoms like sweating, vomiting, giddiness, breathlessness, all these things, which suggests that the myocardial infarction might be happening. What is happening inside is a lipid-rich plaque which is present in the coronary arteries, and because of its necrotic core and the metalloproteinase enzymes, and when there is a thin fibrous cap with a high heart rate as well as high blood pressure, like emotional stress or some other stress, there is a rupture of the plaque and there's a clot gets into the lumen of the artery. So what happens once there is a thrombin comes into contact with the prothrombin gets converted to thrombin, and thrombin in turn converts fibrinogen to fibrin, which activates the platelets, and including the platelets and with a cross-linked fibrin with RBCs and few polymorphs, all these things, a thrombus is there. So in STEMI, it is a red thrombus and there's a complete occlusion of the coronary arteries. That's how the STEMI occurs. Whereas in a non-STEMI, it's always a platelet-rich thrombus, otherwise called as a white clot rather than the red clot. So red clot is amenable for fibrinolytic drugs. So what fibrinolytic drugs do is they convert plasminogen to plasmin, and which in turn dissolves the fibrin into the fibrin degradation products. So this is the basic nature. So as you know, when there is a occlusion, coronary occlusion, within 20 minutes, the damage may not be much. Whereas when it exceeds 20 minutes, the myocardial damage starts from the subendocardial region, and 60 minutes to 3 hours, it spreads almost to the half of the myocardium, and 3 to 6 hours almost the necrosis can be transmural in nature. So when there is a complete occlusion of the artery, it manifests in the form of a ST elevation myocardial infarction. What is ST elevation myocardial infarction is, along with those typical symptoms, if there's an ST elevation in contiguous leads, like lead 1, as you see, lead 1 there is an elevation, AVL there is an elevation, V2 to almost V5 there is an elevation. These are called as contiguous leads. So this is an anterior wall myocardial infarction of an ST elevation type. Similarly, here you can see lead 2, lead 3 and AVF, and also RV leads are showing ST RV3, RV4, RV5. So this is called as a inferior wall myocardial infarction with an RV infarction. So as the time elapses, the ischemic myocardium gradually comes down, whereas the dead myocardium gradually increases. So the lactate accumulation becomes more, and energy rich like ATPs, they go on dwindling. So just to introduce, the cornerstone of therapy in a ST elevation myocardial infarction is to achieve early and complete epicardial and microvascular. That is very, very important. Not only just epicardial, microvascular reperfusion to minimize infarct size, which translates into a preserved LV function rather than reduced or a dead myocardium. So there are two ways of doing this reperfusion. One is a pharmacological with fibrinolytics, and other one is a with primary percutaneous coronary intervention. So see, the reperfusion, if it is done within 40 to 60 minutes, this is called as golden 1 hour, only the necrosis can just remain at the subendocardium, and the myocardial damage may not be much more. Whereas when the reperfusion is as delayed as 90 minutes, we can see almost it is extended to the mid myocardium. So reperfusion done at 3 to 6 hours, so you can see almost most of the myocardium is getting damaged. That's why we should do as early as possible the administration. We have to reperfuse either by a primary PCI, which is the best, or if not by fibrinolytic therapy. Even a 30 minutes delay in administering fibrinolytic therapy, you can see the in-hospital mortality goes on increasing. Hence, there should not be delay more than 30 minutes. One should diagnose a myocardial infarction in doing a fibrinolytic therapy. Even similarly, it holds good for the primary PCI. Within 1 hour, which is just a mortality of 3%, if you go on delaying the reperfusion more than 120 minutes, see it goes on rising, and it may increase up to almost 10.3% when it is around 300 minutes. That's why time is muscle. Immediately you should act in achieving the reperfusion. So these are the latest ESC, European Society of Cardiology guidelines, reperfusion strategy. Primary PCI should be done within the first 3 hours as much as possible. Whereas fibrinolysis is also 1A, that is indicated only if PCI cannot be performed within 120 minutes from the STEMI diagnosis. Then only fibrinolysis is indicated. Similarly, between 3 to 12 hours, again, the primary PCI is the preferred mode, 1A. It is indicated. Only fibrinolysis if PCI cannot be performed within 120 minutes from the STEMI diagnosis. What about 12 to 48 hours if the symptoms are continuing? For example, primary PCI, if hemodynamic instability is there, or arrhythmias are there, LVF is there, definitely you should send again for primary PCI. But thrombolysis or fibrinolytic agents may not be able to help. Whereas primary PCI becomes almost as if it is beyond 24 hours, it becomes 2A if there are continuing symptoms. Routine PCI is not at all indicated beyond 48 hours. It is 3A. See the guidelines segment, primary percutaneous coronary intervention within the first 6 hours, within 120 minutes of diagnosis of STEMI as the preferred reperfusion method to improve survival and decrease the rate of recurrent infarction and intracranial hemorrhage as compared to fibrinolytic therapy. That means it decreases the reinfarction rate, it improves the survival, it also helps in preserving the LV function, and also intracranial hemorrhage chance is not there. But when there is a delay in PCI, there is an incremental increase in mortality. 65 lives are saved per 1,000 if treated within 1 hour, versus 10 lives are saved per 1,000 if treated between 6 and 12 hours. That also one should know. So if there is a STEMI diagnosis from the symptom onset, within 10 minutes, you should immediately do an ECG and send it to a hub hospital. And if you are in the hub hospital itself, the preferred mode is a primary PCI, and it should be less than 60 minutes reperfusion, wire crossing, and achieving the flow should occur. Whereas if it's more than 120 minutes, better just do the fibrinolysis within almost door to balloon time should be within 30 minutes. Door to needle time should be within 30 minutes. So best is a bolus lytic agents rather than infusion of a streptokinase, all these things. Whereas if there is a less than 120 minutes, still primary PCI is the preferred strategy, and within 90 minutes you should achieve a reperfusion. So I think I have clarified all these things. So percutaneous coronary intervention, primary PCI within the first 6 hours. Can it be performed within 120 minutes from STEMI diagnosis? Most of the patients present in the peripheral centers, that means villages or rural centers or community centers. And delay in transfer is also there because of the non-availability of the vehicle, traffic, congestion, social reasons, all these things. Unavailability of catheterization facility there, lack of skilled personnel who can do the primary PCI. Whereas, as you saw, even in high-income countries, only 25 to 50% of patients get primary PCI within 120 minutes. That even in high-income countries like European countries and America. In low and middle-income countries, nearly 3/4 still are treated with fibrinolytics. In India, it's almost 80 to 90%. So, what are the fibrin-specific agents? And they act only on clot-bound thrombin. They are altiplase, a recombinant tissue plasminogen activator, retiplase, and tenecteplase. These two are bolus agents. Okay, this should be over infusion over 90 minutes should be given. Whereas fibrin non-specific like agent like streptokinase and urokinase, and streptokinase administration should be over 1 hour. So indication for fibrinolytic is ischemic symptoms less than 12 hours. It is 1A. That means it is indicated, provided you cannot shift the patient for a primary percutaneous coronary intervention, and it can be achieved within 120 minutes. That means when there are no facilities, this is the preferred choice. Evidence of ongoing ischemia, even 12 to 24 hours after the onset of symptoms and a large area of myocardium at risk, or if there is a hemodynamic instability and PCI facilities are not there or not amenable, then it is 2A, still can be given. And whereas ST segment depression, that means non-ST elevation, non-MI, and unstable angina, it is harmful. It is not indicated. So what are the absolute contraindications? Was absolute contraindication like previous intracranial hemorrhage or a stroke of unknown origin at any time, ischemic stroke in the preceding 6 months, Central nervous system damage or neoplasms or arteriovenous malformations. Recent major trauma, surgery, head injury within the preceding 1 month, gastrointestinal bleeding within the past month, known bleeding disorders, excluding the menses. Menses is not a contraindication. Aortic dissection, when there is a BP difference between both the upper limbs or upper limb and lower limb, then you should suspect in a hypertensive individual aortic dissection if there is no ST elevation in the ECG. And non-compressible punctures in the past 24 hours, like having done a liver biopsy or a lumbar puncture. So these are all absolute contraindications. The relative contraindication is a transient ischemic attack in the preceding 6 months. Oral anticoagulant therapy is already patient is if he is taking. Pregnancy, if it is there, it is a contraindication, or within 1 week of postpartum. Refractory hypertension, BP being more than 180 by 110, which can be controlled with antihypertensive agents. Once it is less than 160/90, you can go ahead and do the thrombolysis. Advanced liver disease because of the coagulation factors being deranged. Infective endocarditis, active if it is there. Active peptic ulcer, prolonged traumatic resuscitation, more than 10 minutes if you are suspecting internal injury, then also it is contraindicated. These are the three agents. Tenecteplase is a bolus fibrin and it's very highly fibrin specific. Retiplase is also 10 units and 10 units late to be given after 30 minutes. Again, fibrin specific. And see the TIMI3 flow, that means almost like a normal flow, achieved 85% with tenecteplase, 84% with retiplase, altiplase 73 to 84%, but it should be given over 90 minutes infusion. Streptokinase 1.5 million units given over 30 to 60 minutes, and it causes patency rate of 60 to 68%. It is less compared to the fibrin specific agents. So what are the choices? Ease of dosing is important, like bolus agents, cost, whereas bolus agents are costly, whereas streptokinase is a cheaper drug, which may be amenable to low socioeconomic status patients, all these things. Bolus fibrinolytics have a lower chance of medication errors, are associated with less non-cerebral bleeding, offering the potential for pre-hospital treatment also. So early presentation and acceptable bleeding risk, fibrin-specific agents like tenecteplase, retiplase, or altiplase are preferred. Risk of death is low, or where there, for example, where there is chances of intracranial hemorrhage risk is more, then give streptokinase only. Avoid the fibrin-specific agents. Tenecteplase is the preferred drug, followed by retiplase as a bolus agents less than preferably 75 years of age. So streptokinase most commonly used, approved for MI use in 1987, easy availability, low cost, 15 lakh units given over 30 to 60 minutes in 100 ml of saline. Systemic lytic state, plasma half-life is 30 to 80 minutes, but it is antigenic. Allergic reaction can occur, fever, and rarely even hypotension can be there, arrhythmias can occur, and anaphylaxis to the extent of 1 to 2%. So keep all emergency drugs by the side when you are giving streptokinase. Hypotension, if it is there, foot end elevation and fluid administration. And its reuse in the first 6 months is not possible because of antibodies. Reperfusion rate at the end of 90 minutes is 60 to 68%, and TIMI3 flow, almost like a normal, this thing is 30% only. So one vial contains 15 lakhs, mix with 100 ml saline and to be given 30 to 60 minutes, and you should have a complete continuous ECG, SpO2 and BP every 5 minutes. It should be watched, and watch for reperfusion arrhythmias. This is the study which has shown benefit, GISI-1, the first large trial that showed a significant mortality reduction with a fibrinolytic agent was the landmark GISI-1 trial. 11,800 patients with acute MI presenting within 12 hours of symptom onset were randomized to either reperfusion therapy with streptokinase or standard non-fibrinolytic therapy. The in-hospital mortality rate was 10.7% in patients treated with intravenous streptokinase versus 13.1% in controls, resulting in 23 lives saved per 1,000 patients treated. This benefit in mortality was preserved at 1 year and 10 years of follow-up. Very, very important. Similarly, in the ICIS-2 study also, streptokinase along with aspirin lives saved was almost to the extent of 42%. And in Altiplase, with this RTPA, greater fibrin specificity than streptokinase induces mild systemic fibrinogen depletion. And these are the two studies in two mortality trials, ICIS-3 and GIST-2. Altiplase given as a 3-hour continuous infusion was not superior to streptokinase, but accelerated dose when given over 90 minutes, as in GUSTO trials showed mortality reduction. But limitation is it's a complicated dosing schedule. Patency rate at 90 minutes 75 to 84% and TIMI-3 flow in 54% only. And retiplase is a mutant of altiplase, lesser fibrin specificity but considered equivalent to TPA, longer half-life, and because of higher recursion rate, double bolus regimen is preferred. Dose is 10 units and followed by another 10 units to be given over 30 minutes apart. Patency rate is 75% and TIMI-3 flow is 60%. GUSTO-3 trial compared retiplase with the TPA in 15,000 patients. Retiplase is not superior, but it is almost equally efficient. RAPID-1 and RAPID-2 reported earlier higher patency with retiplase as compared to TPA. Tenecteplase, the third generation, a product of 3-point mutation of TPA, TNK TPA called as, increased fibrin specificity, 14 times more specific, decreased plasma clearance, plasma half-life of 20 minutes, reduced sensitivity to PAI1, 80-fold more resistant compared to TPA, and single bolus 0.53 milligram per kg given over hardly 5 seconds. That means just a bolus dose. No paradoxical procoagulant effect, and it's got a lower bleeding. Patency rate is 85%. TIMI-3 flow is 63%. Maximum achieved. TIMI-10B and ASCENT trials showed it is equivalent to TPA and lower non-cerebral bleeding. And Elaxim registry from our own country, reperfusion rate achieved is almost 91%. So, as you know, even in our Indian registries, CREATE registry, Kerala ACS, Himachal Pradesh, see, thrombolysis is the main modality of reperfusion, almost to the extent of almost 40 to 60%. And maximum is most often done with streptokinase only. And see, the primary PCI is hardly done in these registries, 8%, 12% only. That means still we are depending on fibrinolytics rather than primary PCI in our country. So the dose I have already told you, tenecteplase single IV weight-based bolus, 0.5 milligram per kg. So almost 30 to 40 milligram as a bolus. Retiplase 10 and 10 units to be given 30 minutes apart. Altiplase is a 90 minutes weight-based infusion. And streptokinase, although I have already enumerated how it should be administered. And timing and mortality reduction is time dependent. I told you the first 1 to 2 hours is the best. Reduction FTT collaborative group, 18 to 25% mortality reduction with thrombolytic therapy. Late and MRS trials showed that between even 6 and 12 hours, there is a mortality benefit that is 13% still persists. Hence, you should not refuse. You should go ahead and do if there are ischemic symptoms beyond 6 hours also. But the best outcomes are with thrombolytic therapy in the first 1 and 2 hours after the onset of symptoms, which is called as a golden 1 hour. What is the preparation you have to do? Check the BP in both arms. There should not be any difference. Continuous ECG, SpO2 and BP, every 5 minutes they should be checked. Oxygen if SpO2 is less than 90% only. 18 gauge IV line, and they should be ready for IV fluids, everything. And prepare for hypotension, like keep the dopamine, noradrenaline, and of course for anaphylaxis, equivalent hydrocortisone and normosaline drip, all these things. Keep IV Lasix ready in case if there's a pulmonary edema. And of course, a defibrillator should be by the side, either in the hospital where you are administering or in the ambulance if you are administering a bolus. So what is a successful thrombolysis? Resolution of ST elevation by at least 50% compared to basal ECG at 60 to 90 minutes from starting thrombolytic therapy. That means a basal ECG which has shown an ST elevation, you should repeat the ECG after 60 minutes of thrombolysis and see is there any ST resolution of more than 50%. That shows that there is a resolution or there may be a probably epicardial coronary is resumed. Relief of pain and symptom relief also indicate that epicardial flow has started. A new reperfusion arrhythmia like accelerated idioventricular rhythm and sometimes VT can be there and you should be ready to tackle them. AIVR doesn't require any treatment, but VT, if it is going on for a little more time, probably if it's causing hemodynamic instability, you have to treat it immediately with like Xylocard infusion or even rarely amiodarone. Attaining hemodynamic stability is very important, and of course, with thrombolytic therapy, usually if it is a successful, it will be stabilized and resolution of hypertension. What about in elderly? Elderly form 15% in trials and 35%, almost 1/3 in registry data. The absolute reduction in mortality, same as young people. Hence, you should never refuse thrombolysis even in elderly. The risk of intracranial hemorrhage and mortality more as the comorbidities are also more in elderly, and that should be taken care. What about late thrombolysis, more than 12 hours? Risk of mortality, especially in the elderly, is more. Especially myocardial ruptures can be there, intracranial hemorrhages can occur, and reperfusion injuries more. That's why you should try to avoid and send them for a primary PCI rather than doing a thrombolysis more than 12 hours. PCI is preferred if presenting after 12 hours. Fibrinolysis only with ongoing ischemia with a large area at risk or unstable hemodynamics or any electrical instability, and when PCI facility is not available, at that time only you can go ahead and do it. What are the complications you expect following thrombolysis? Bleeding complications are most common, almost to the extent of 1 to 12%. Major bleeding is little less. Intracranial hemorrhage is the most serious. Well, how much is the incidence? Hardly less than 1%, but varies with the clinical characteristics of the patient and the fibrinolytic use. More fibrin specific, little more chances. Streptokinase, less chances. So who are the patients? Risk of stroke, risk factors for intracranial hemorrhage are advanced age, more than 75 years, lower body weight, female sex, prior cerebrovascular disease if it is already there, or a systolic and diastolic hypertension on admission. That means uncontrolled hypertension. And I told you it's hardly 1% of patients there can be intracranial bleeding. And is increased risk of bleeding, especially in patients undergoing prolonged or traumatic resuscitation, may occur. So what is failed thrombolysis? Worsening ischemia, that means person has not improved, no ST resolution, hemodynamic and or electrical instability is occurring, pulmonary edema is occurring, arrhythmias are coming, ST segment resolution is less than 50% in chest leads and less than 75% in inferior leads on an ECG, then at 60 minutes, then definitely immediately shift for a rescue PCI. Post-thrombolysis transfer routinely to a PCI center for coronary angiogram is required. Within 2 to 24 hours, the patient will need an angiogram, even if there is a successful fibrinolysis. Ensure that an ambulance is on standby when you decide to thrombolyze. Monitor is required during the transport and defibrillator also should be there, oxygen facilities, and usually to be shifted with a doctor. Call the hub hospital ahead of time for further coronary angiogram and PCI facilities, all these things. So just to conclude my talk, in ST elevation myocardial infarction, time is muscle, take immediate decision. Administer all necessary medicines like soluble aspirin, high-dose statins, clopidogrel, IV heparin 4,000 units. If comorbidities are there, try to control them to the goals if possible and relieve pain and reduce anxiety immediately. Transfer to a PCI capable hospital only if transport time is less than 30 minutes, door to balloon time is less than 60 minutes, and total time from ECG to PCI is less than 120 minutes. If not, go ahead with thrombolysis, taking all necessary precautions and choosing appropriate thrombolytic drug as per patient's need, age, and socioeconomic status, and under continuous monitoring of ECG, heart rate, BP, and SpO2 throughout the administration. Repeat ECG after 60 and 90 minutes from start time of thrombolysis infusion for resolution of ST elevation and symptom relief and hemodynamics for a successful or a failed thrombolytic therapy. Failed thrombolysis needs urgent rescue PCI and needs immediate transfer to a PCI capable hospital. Even if thrombolysis is successful, patient needs a transfer to a PCI capable hospital for coronary angiogram within 2 to 24 hours of thrombolytic therapy and needy interventions according to the anatomy of underlying coronary artery disease. Thrombolytic therapy is a boon in our country to save lives timely and to buy time to transfer the STEMI patient to a PCI capable hospital for further management as per scientific indications. I think with this, I end my talk. And if there are any queries or questions, kindly ask the same. I once again thank the IJCP for this opportunity as well as Nishita Mukherjee. Thank you.
Thank you so much, sir, for the wonderful presentation. So with your due permission, shall we move forward to the question answer round?
Yeah, definitely.
Sir, we already received questions. First question we received, that is, what is the efficacy of percutaneous coronary intervention of thrombolytic therapy of STEMI? I think you have already elaborated it, but could you please say in one line the answer?
So following coronary thrombolytic therapy, if there's a failed reperfusion, that means if there's no ST resolution in the ECG, which is taken 60 to 90 minutes later following a thrombolytic bolus or a therapy, and if there is a continuing symptoms are there, hemodynamic instability, BP is falling, patient has gone into pulmonary edema, and he has got arrhythmias. These are called as hemodynamic instabilities. And he should be immediately shifted for rescue PCI to a PCI capable center. Even otherwise, if there is a successful thrombolysis, ST resolution has occurred, and definitely symptom relief is there, patient is stable, still within 3 to 24 hours, kindly shift to a PCI facility center just to know the underlying anatomy, and if there is any underlying coronary artery disease which is significant, we call significant if the left main stem is more than 50% blocked, and if there's a proximal coronary arteries are more than 70% blockage is there. They are called as significant coronary artery disease, and they need a relief from balloon angioplasty or if necessary even stenting. So these are all the indications for PCI following thrombolysis.
Thank you so much, sir. Moving towards our next question. What are the limitations of PCI in the treatment of STEMI?
Limitation of PCI, see, it is always time bound. If the person is having a ischemic symptoms, and if it is if the PCI capable center is there and an experienced person is there, immediately if there is an ST elevation, load the patient with soluble aspirin, clopidogrel, IV heparin, high dose statins, and if necessary like beta blockers, ACE inhibitor, if the hemodynamics is permitting, and immediately shift to the center for a coronary angioplasty, otherwise called as primary PCI. Only when the primary PCI can be done even up to 12 hours, that is the best period. But as the time goes on increasing, I told you, Within the first 1 to 2 hours, the mortality is hardly 3%. When it is more than 5-6 hours, then the mortality goes on increasing to almost 10%. That's why the more you delay, already the LV is damaged. So achieving, even though you achieve the TIMI 3 flow, the what you are going to achieve, LV dysfunctions and still occur, and patient can go in for heart failure later. That's why try to keep the ischemic symptoms within 120 minutes for a primary PCI. But of course, if there's a delay on the part of the patient himself, you cannot help because of the educational problem, social problems, and other accessibility problems and non-ability of the hospital facilities, then you cannot help. Whenever he comes, if he comes within 12 hours, because it is beyond the thrombolysis benefit, better to send him for a primary PCI. Even if there are continuing ischemic symptoms beyond 12 hours, then better to send him for a primary PCI rather than a late thrombolysis, because late thrombolysis has got disadvantages. I told you, myocardial rupture can be there. And of course, what we achieve also may not be much because already LV dysfunction might have occurred because of the late reperfusion injury, all these things. So this is all what I can convey to you.
Thank you so much, sir. The second last question of today's session is, what are absolute contraindication for fibrinolytic use in STEMI?
Any old intracranial hemorrhage, of course, if there is a neoplasm like brain tumors or even a metastasis, is a contraindication. Any stroke within the last 6 months is an absolute contraindication. And of course, any bleeding, active bleeding in the body is a contraindication. Peptic ulcers recently diagnosed, then if there are active ulcers, is a contraindication. Pregnancy is an absolute contraindication. Head injury in the last 1 month or recent surgeries within 15 days or 2 weeks, then again these are all absolute contraindication. You should not. And traumatic resuscitation, if you are already suspecting an injury inside, then also it is an absolute contraindication. So these are some of the things.
Thank you so much, sir.
Yeah.
We are taking last question of today's session, that is, what are relative contraindication for fibrinolytic use in STEMI? I think both the questions are almost same. Only the difference is relative contraindications.
Relative contraindication, for example, you have done a traumatic, so for example, CPR is already done, but still you do not suspect an internal injury, still you can go ahead and give thrombolysis, provided you do not suspect any internal injuries. Of course, the other one is if there is a stroke within the last 3 months, is there for ischemic stroke within the last 6 months, is a relative contraindication. TIA within the last 6 months is a relative contraindication. So, of course, I told you, peripartum 1 week, better to avoid the thrombolysis. And any blood pressure more than 180/110 is a relative contraindication, because you can control the BP with IV antihypertensives, and once it gets controlled, you can still go ahead and do the thrombolysis. So these are some of the relative contraindications. And of course, streptokinase, if it is given within 6 months, you should not give streptokinase, but you can definitely give other thrombolysis agents like retiplase, tenecteplase can be given within 6 months also, other thrombolysis. So there are relative contraindications, but of course, you cannot give a streptokinase in the same individual. Thank you.
Thank you so much, sir, for the wonderful presentation. And I hope all the participating doctors, your queries has been resolved. And I would like to thank all of you for attending today's session. So, sir, with your permission, shall we conclude the session here for today?
Thank you.